Good afternoon, everyone. Yazeed Sawalha from the Ohio State University. Very happy to be talking to you today about navigating initial treatments. These are options for patients new to treatment. I do want to thank the foundation first for having this forum here in Columbus. I know a lot of patients appreciate that. I also want to thank them for inviting me. I'm very happy to be here to talk to you about this topic. These are my disclosures. So I'm going to start with a very brief introduction. I know there was a talk earlier today about the basics of Waldenstrom, so I'm not going to go over everything. I just want to highlight a few important things that are related to the topic. I want to talk to you about some treatment considerations, so things I think about while I'm reviewing the chart before I meet the patient, things I want to ask about while I'm talking to the patients, and just considerations before I recommend a treatment or two for my patient. And then we're going to spend most of the time talking about treatment options, the one listed here. And then I'm going to give you my approach for treatment for most patients. And then we should have plenty of time at the end for questions. So you probably have heard that the bone marrow is the factory where all the healthy red blood cells and white blood cells and platelets are made. We have different types of white blood cells. We have the lymphocytes. The lymphoma is a cancer of these lymphocytes. And then we have different types of lymphocytes. We have B cells, T cells, NK cells, and plasma cells. Waldenstrom is a type of B cell lymphoma, so it comes from these B cells. If you see this kind of picture here, that's a normal, healthy-looking bone marrow. These white kind of big cells are just fat cells. We don't care much about them. But you might maybe appreciate that there are many different looking cells. And this is how a normal bone marrow should look like. You should have different types of cells that make all the healthy white blood cells, red blood cells, and platelets. Now, the B cells and the plasma cells have a unique feature. They can make antibodies. Antibodies are proteins that the body uses to fight infections. We call these antibodies also immunoglobulins. We have different types of antibodies or immunoglobulins. We have immunoglobulin A or IgA, IgD, IgE, IgG, and IgM. You can see here that the IgM is actually 5 antibodies kind of linked together. And it's much larger than the other types of antibodies. And that's important for a reason we're going to talk about in a minute. So this is just all normal process in everyone, all of us. Now, in Waldenstrom, what happens is that one of these B cells, one of these B lymphocytes, start growing in an uncontrollable way. And that's just cancer, that's lymphoma. In this example here, the cells are growing in the bone marrow, and maybe you can appreciate that here, all the cells kind of look the same because all kind of came from within one cell, and then they took over the bone marrow and kind of kicked out the healthy cells that make the healthy red blood cells and white blood cells and platelets, and that can cause symptoms and problems. And many times these cancerous B cells, the lymphoma cells, can continue to make the antibody, which most commonly is the IgM in our cases. Now, this IgM, the antibody, because it comes from abnormal cells, we consider it abnormal, and we call it monoclonal protein or an M protein. So when we say an M protein or monoclonal protein, it's the antibody that comes from the abnormal B cells or the lymphoma cells. This is an example for one of my patients. We checked the immunoglobulin G, A, and M. The G and A, the IgG and the IgA were low. If you look at the far right is the beginning. But the IgM was high because the lymphoma cells were making excess of it. And then there's a special blood test where we can identify this abnormal protein, the monoclonal protein. It's also listed there, the monoclonal protein, and it's the IgM subtype. We gave the patient treatment, and then the levels came down as we expect and hope to see. You probably have also heard that Waldenstrom is a type of treatable but generally considered incurable lymphoma. That means that we give treatment. Most of our treatments, thankfully, work and tend to work for years. But we still expect the lymphoma to come back at some point, to the point where we have to treat it again. Now, even though it's incurable, because it's slow growing and because we have so many good treatments for it, most patients are able to live with it for many, many years. And most patients end up dying with the lymphoma, not from the lymphoma. Unfortunately, that's not the case for everyone. Sometimes the lymphoma can become hard to treat or resistant to treat. Sometimes our treatments just don't work or just work for a short period of time. And Waldenström can become more serious and potentially life-threatening. But fortunately, that doesn't happen to most patients. Waldenström is a type of slow-growing lymphoma, and slow-growing lymphomas can change or transform into aggressive lymphomas. And that's very important for us to know because we treat aggressive lymphomas very differently than slow-growing lymphomas. So how do patients, or why do patients have symptoms from Waldenström? It could be one of few things, and sometimes more than just one thing. First of all, the cells could just take up room or space away from healthy cells. So if the cells grow in the bone marrow, just like in the picture I showed you, there wouldn't be enough space for the healthy cells to make healthy red blood cells. So patients might have anemia, they might look pale, feel short of breath, feel tired. If it takes room away from platelets, you'll have low platelet count, and that can increase the risk of bleeding and bruising. If it takes away space from white blood cells, that can increase the risk of infections. If the lymphoma cells are growing in lymph nodes, the lymph nodes could enlarge or grow. That can cause some discomfort or pain potentially. If they grow in the spleen can become enlarged. Lymphomas, including Waldenström, can grow in virtually any organ. They can grow in the brain and the spinal cord. That fortunately is very, very uncommon, but we have a special name for it. We call it Bing-Neal syndrome. That's when Waldenström is impacting the central nervous system, the brain or the spinal cord. And then again, any other organs like the kidneys, the liver, the lungs, etc. So that's one way. The second way is from this IgM, the abnormal IgM, the monoclonal protein. If you remember, I told you this IgM is a large molecule. It's much larger than the other ones. And if you have very high levels of it, very high amounts, it can actually make the blood thicker than normal or viscous. And that can make the blood flow sluggish in the arteries and veins and the very small blood vessels. If that happens, if the blood flow to the brain, for example, is sluggish, patients can have headaches or confusion. If the blood flow to the heart or the lungs is sluggish, patients can have shortness of breath or chest pain. And the very small vessels, if they're engorged because the blood is not flowing, these small vessels can rupture, so patients can have bleeding. They can have nosebleed, for example, or they can have bleeding in the very small vessels in the back of the eyes or the retina, and that can cause vision blurring or floaters. We call all of this hyperviscosity syndrome, which just means that the blood is more viscous or thicker than normal because the IgM levels are just much higher than normal. The third way is that this abnormal protein, the IgM, can bind to cells and organs and tissues that it shouldn't bind to. So, for example, if the IgM binds to the nerves, it can irritate the nerves, and patients can have numbness and tingling in their feet, for example. If it binds to red blood cells, it can clump them together, and that can lead the immune system to go and attack these clumps of red blood cells and destroy them, and patients can have anemia, or what we call hemolytic anemia. If the IgM binds to very small blood vessels, it can cause inflammation in these blood vessels, something we call cryoglobulinemia. And then sometimes parts of the protein can get deposited in tissues, and it can cause damage to the tissue. So for example, if parts of the protein get deposited in the heart muscle, it can form a glue-like substance, and instead of the heart muscle being able to squeeze very strongly, it becomes stiff and it can't squeeze as strong, and that can cause symptoms of heart failure, like for example, shortness of breath or swelling in the legs. There are a few mutations that are worth mentioning when we talk about Waldenström. You might have heard about the MYD88 or the MYD88 mutation. Most patients with Waldenström have this mutation, up to 95% of them. It's very helpful for us as physicians to know these mutations because it can confirm the diagnosis of Waldenström. Waldenström sometimes can look like other types of slow-growing lymphomas, and having this mutation can confirm our suspicion. Now, maybe up to 10% of patients with Waldenström might not have it, so not having the mutation doesn't exclude the diagnosis of Waldenström, but it will make us think twice whether we're really dealing with Waldenström or some other type of lymphoma. And then there's a mutation called the CXCR4 mutation. That mutation is present in up to 40% of patients. It can actually make the lymphoma cells a little bit harder to treat. It can give them an advantage to become resistant to treatment. And those patients tend to have slightly more aggressive disease. So their IgM levels might be higher. They are a higher risk of having this hyperviscosity syndrome and other symptoms from Waldenstrom. And then the last mutation is called TP53. This is fortunately is very uncommon in patients who are newly diagnosed with Waldenstrom, in less than 5% of patients. It does become a little bit more common or more prevalent as patients go through different treatments. This mutation also makes the lymphoma cells harder to treat. They become more resistant to treatments. That doesn't mean that treatments won't work, but the chances of them working might be lower and they might not work for as long. So these are some of the things I think about even before I go and see a patient. The first thing when I'm reviewing the chart, this is like before I see the patient for the first time in clinic, I'm reviewing the chart, reviewing the labs, the scans, everything, and I'm thinking, should I offer treatment for this patient? Does this patient need actually treatment, or can we watch or observe this lymphoma? So the default in the slow-growing lymphomas, including Waldenstrom, is that we watch or monitor unless there's a reason to treat or an indication to treat. And these indications can be things like symptoms. So B symptoms, for example, so fevers, night sweats, weight loss, significant fatigue that we can attribute to the lymphoma. And it's not easy. In real life, usually there's usually more than one reason why a patient can be fatigued. And there's no one blood test or one scan that I can do to tell you that 75% of your fatigue is from lymphoma, for example, and the rest is the other problem. So that's not really simple. We can have to talk and review what other things could be contributing, and then kind of make a decision if we think the fatigue is mostly from the lymphoma or maybe something else. Sometimes if the patient doesn't have symptoms, but they have high disease burden or large volume of disease, we might recommend treatment. For example, the lymph nodes are just very big, where I'm worried the patient is going to start having symptoms in the near future. Or these lymph nodes are big enough to the point where they start compressing on vital organs, like, for example, the kidneys or the lungs, liver, etc. So in those cases, even if the patient doesn't have symptoms right now, I might say it might be risky to actually monitor. Let's just go ahead and do the treatment. The third one, if there are significant lab abnormalities. So not just any lab abnormalities, they have to be significant. So mild anemia is not typically considered significant, but a hemoglobin level less than 10 we consider significant because we expect patients to have symptoms at that point. A platelet count less than 100,000, for example, we consider significant. And there are other values too, but the point is not just any abnormal labs, they have to be significant enough to warrant treatment. The IgM level by itself is not typically considered an indication to treat, although when the levels are very high, generally more than 5,000 to 6,000, I at least become very nervous about it because I worry about this hyperviscosity syndrome and all the potential serious complications that can happen from it. So if I have a patient with an IgM level of more than 5,000 or 6,000, even if they're feeling fine, I might say, you know what, I'm just worried that you might have this hyperviscosity. Let's just do treatment now. This is somewhat controversial among lymphoma physicians. Some other physicians might say, no, actually, if you don't have symptoms, let's just keep a close eye on you and only start treatment if you start having symptoms from the IgM. So your kind of doctor might approach it a little bit differently. So the first thing I think about is should we treat or not? And then actually a little bit more on that. So the concept of having cancer or lymphoma and not getting treated can be very distressing for patients because we're all wired to think about early detection of cancer. You think about mammograms for breast cancer and colonoscopy for colon cancer. And then you go see your doctor for the first time and they tell you, yeah, you do actually have cancer, but we're just going to see you in 3 months. Don't worry about it. And that can be very distressing for a lot of patients. So patient will ask me, why would we treat? And I answer the question by asking them a question. And they say, if you think about it, why do we treat cancer in general? And it's usually one of 3 things. 1, to cure the cancer. And unfortunately, right now, we can't cure Waldenstrom. Hopefully that will change one day, but as of today, we can't give you a treatment and promise that there's a chance we can cure it. That's just not true. The second one, even if we can't cure the cancer, maybe we can make the patient live longer. Right now, there's no evidence that being proactive or starting treatment early will actually change the overall outcomes. There doesn't seem to be any benefit from trying to be more aggressive or more proactive. And we feel comfortable saying, by delaying treatment, we're unlikely going to harm you. The third reason is maybe we'll just make you feel better. Even if we're not going to cure it or make you live longer, just make you feel better. Well, I just told you, you don't have symptoms to start with. If I give you treatment, I'm probably not going to make you feel better. I'm probably will put you at risk of having side effects that will make you feel not better. So that's how I kind of approach it. There's no harm, and you're probably not going to feel better if we give you a treatment, if you don't have symptoms to start with. Obviously, if you have symptoms, we give you treatment, we hope you're going to feel better. It takes time to kind of, for this to, for the patient to get used to this concept. It does take time. You start with thinking about the lymphoma every day, almost every day, and then with time it eases. It gets to the point where you're just thinking about it for maybe a few days a week, and then maybe a few days a month, and then more often before you come and see us in clinic, because that kind of brings it up. But it does take time, and that's normal. We're humans. We have emotions, we worry, but it does get better for most patients. And it's feel okay to just, bring it up every time to your doctor and to say, why aren't we doing this? And hopefully they'll give you a good explanation, and that will reassure you. So first thing I think about again is, should we treat or not? And then if we need to treat, what symptoms does the patient have? Do they have large volume of disease or low volume of disease? How urgent do they need treatment? How soon do I need to make the symptoms get better? Is that something that can wait for a few weeks, or are there like serious or life-threatening complications that need to be treated right away? Because that could impact my treatment recommendation. And then the patient themselves, obviously, their age, how strong they are, how fit or unfit they are, what other medical problems they have, could also impact my decision and my recommendation. Fortunately, for most patients, we can recommend at least one treatment option, even if the patient is very old, even if they have a lot of other medical problems. It's very, very uncommon when I have a patient with Waldron's syndrome, I go in and say, I'm sorry, I can't offer you anything, for a patient who is newly diagnosed. That's very, very, very uncommon. And then last but not least is what the patient wants, so their goals and wishes. Again, most of the time we're able to offer them more than one treatment. So we might offer 2 or 3, for example, go over the advantages and disadvantages of each, and then make a decision together. It might be that the most important thing for this particular patient is that they don't want to miss work, for example, and so they don't want to come here twice a month for IV infusions, or the cost of the drugs, the pills, might be prohibitive for them, so they'd rather get IV infusion because they might have a lower copay for that, for example. Or they just golf every summer and they don't want to miss any day. Or they're going to go back and forth between Ohio and Florida, and so they want a pill because they don't want to get stuck in Ohio in the winter to get infusions, for example. So these are things that, fortunately, because it's slow-growing lymphoma and we can treat it with many options, we can go back and forth and discuss what's the best for the patient. In other types of cancer, sometimes, unfortunately, we just come and say, we really have to do this. There's really no wiggle room. This is the treatment. We kind of have to do it. Obviously, we don't force patients, but we can't offer them good options for some other types of lymphoma. Okay, I mentioned that kind of the watch and wait, or this observation, is the default. So a very common question is, for how long can we observe this cancer when I'm going to need treatment? Obviously, I can't tell a patient, when exactly they're going to need treatment. Sometimes looking at their history can be very informative. So if I have a patient who had maybe some enlarged lymph nodes 5 years ago that other doctors didn't really pay attention to, and then they slowly grew with time, and then one day someone did a biopsy that showed Waldron's, and they come and see me, I can tell them, you've had these lymph nodes for 5 years, they've really barely changed. I can tell you that it's unlikely that something is going to happen in 6 months or a year, because I can look at what happened over the last 5 years and can predict that it's unlikely that things are just going to change rapidly. I'm guessing somewhat. There's no way to know for sure. The growth of the cancer cells is not always linear. It's not always a straight line. Things could change. Sometimes they even wax and wane. But that could be a good way for me to give them an estimate. There's this online tool. It's an online risk calculator where your doctor can put in some information to give you an idea of when to expect treatment. You have to have a bone marrow biopsy first because we need the percentage of the lymphoma cells in the bone marrow. Not all patients have bone marrow biopsies for Waldenström. Most of them do, but not all of them. And then the pathologists don't always report this percentage of lymphoma cells, so that can be a limitation. And there are 3 blood tests: the IgM protein level, a protein called beta-2 microglobulin, and then albumin. And then we plug in these numbers, and the calculator will give us one of 3 answers: either low risk, intermediate risk, or high risk. The low risk means that there's a 50% chance you won't need treatment until at least 9 years. The intermediate risk is that there's a 50% chance you won't need treatment until 5 years. And then the high risk is for 2 years. So it can give you an idea. You're talking about a year or 2, 4 or 5, or more than 9. It's not perfect, so I might tell a patient 50% chance for 5 years, and then the lymphomas start growing and warrant treatment in a year, for example. Or I might say 5 years, but it wouldn't take them 10 or 15 years. So it's not perfect, but it can give you an idea. Another common question is, patients will ask, what are the chances of a treatment working? And there we can have to clarify what works actually mean. So what do we mean when a treatment works? What exactly do you want to see? So there are these response criteria. They're not super important. It's not the point. The point is not about the percentages and the numbers, but I just included these to kind of tell you the things we look at when we are assessing whether a treatment works or not. These are also tools that we use in clinical trials. So if you at any point read a clinical trial result, you might come across these definitions. Some of the physicians, also some of the doctors, might actually include these in their progress notes. You might read it in your clinic notes. A doctor might say the patient responding, they achieved a very good partial response. You might wonder what exactly that means. A complete response is the best response we can get right now. And it basically means that the IgM protein goes down to normal levels. We don't see the M protein, the monoclonal protein anymore, so it disappears. We do a bone marrow biopsy, and we can't find the lymphoma cells anymore. And then we do scans, and we don't find any enlarged lymph nodes or enlarged spleen or anything else abnormal. That's very, very uncommon right now with the treatments we have. So most patients are not able to achieve this complete response. In fact, we don't do bone marrow biopsies on patients after we start treatment because we don't expect the bone marrow to be clean for most patients anyways. We only do a bone marrow biopsy if we worry that it might be something else that's causing the low blood counts, or if we worry just that the treatment didn't work and there's still a lot of lymphoma cells in the bone marrow. The very good partial response is kind of the next best response. That's when you have a 90% reduction in the IgM. So let's say we started at 5,000, I gave treatment, and then the IgM went from 5,000 to 500. That's a 90% reduction in the IgM level. That's called a very good partial response. A partial response is at least 50% reduction in the IgM. So we started at 5,000, went down to 2,000. That's a 60% reduction. More than 50%, that's a partial response. And then a minor response is 25 to 49%. A stable disease is when the IgM doesn't really change much, less than 25% either way. And then progressive disease is when the IgM goes up by at least 25%, and the change in the level has to be more than a 500 milligram per deciliter, or if there are new lymph nodes or enlarged spleen. So this is very important. Sometimes I give treatment, we start at 5,000, the IgM goes down to 500, the patient's doing great, we see them in clinic, and then the next time the IgM goes up to 600, and the patient is worried that the lymphoma is getting worse. And I would tell them, although it did go up, it didn't go up a lot, it's not 25%, it's not a 500 milligram per deciliter difference. Let's check it again next time and see. If it goes up next time to 1,000 or 1,200, then yes, that's progression. But if it doesn't, then it was just a false alarm. These numbers can sometimes fluctuate. So that's why the criteria are a little bit strict. It has to be more than 25%. It has to be at least 500 milligram per deciliter, and it has to be confirmed on 2 consecutive readings before we call it progression. Now, if the patient comes in and they have a lot of symptoms and their hemoglobin is really down, that's a different story. We don't always have to kind of wait 3 months, etc. But if they're doing fine otherwise, we just don't make a decision just based on one lab reading. And then there's something called the overall response rate. That's kind of lumps minor response and higher. So having achieved at least 25% reduction in the IgM, and then major response rate when you have at least 50% reduction in the IgM. Again, the details, the percentages are not super important, just to kind of tell you how this is done, and you might again see it in your clinic notes. Okay, another very common question is, we give treatment and the patient, or even before we give treatment, the patient will ask, well, how long the treatment is going to work for? Unfortunately, there's no way for anyone to tell you for how long the treatment is going to work for. Like, I can't tell a patient your lymphoma is going to start getting worse in June of 2032. Wish we could, but we can't. But we can talk about something called the median time to progression. So let me tell you what that means. So just imagine with me that I have 11 patients with Waldenström in my clinic. I'm going to see all of them on the same day. I'm going to give all of them the same treatment on the same day. And I'm going to see all of them every 3 months in clinic for, let's say, 15 years. And then the end of these 15 years, I'm going to ask all of them to come to clinic on the same day. We're going to go to the hallway in the clinic. I'm going to ask them, you have to stand in line in order when your lymphoma started getting worse or progressing. And I have a sheet of paper with kind of, the dates it took for, or the duration it took for each patient's lymphoma to start getting worse. So I pull up the sheet, I say, Mrs. A, your lymphoma came back first. At 6 months, go to the first spot. Mr. B, your second in a year, go to the second spot. And then I go through the 11 patients. And then I go to the patient number 6. So that's the patient in the middle. There are 5 patients before him and 5 patients after him. Let's say this is Mr. Smith. And I ask Mr. Smith, when did your lymphoma start getting worse, progressing? He says 5 years. That's the median time to progression. That's the point of time where the lymphoma for half of the patients has started getting worse, and the point of time where the lymphoma didn't get worse until after the 5-year mark. So that's when I tell a patient the median time to progression is 5 years. It means that there's a 50% chance that your lymphoma is going to start getting worse within 5 years. And 50% chance is not going to start getting worse until after 5 years. Hope this makes sense. If it doesn't, let me know. We can talk about it again at the end. Now, I can't tell a particular patient if they're going to be, again, number 1 or 2 or 4 or 7 or 9. There's no way to know that. I can give them an estimate as a group. But there could be some factors where I might be able to guess if you're going to be in the first 5 patients or the later 5 patients. So for example, if a patient has this CXCR4 mutation where the lymphoma cells are more likely to be resistant to treatment, they're more likely to be in the first 5 patients because their lymphoma is just more resistant to treatment. That's not a guarantee that their lymphoma is going to come back within 5 years or start growing within 5 years. It's definitely not a guarantee, but it's more likely than not that it will. The same thing with the TP53 mutation. On the other hand, if you don't have the CXR4, then the odds are maybe you're more likely to be in the second group where the lymphoma doesn't start getting worse until after 5 years. It's not a perfect rule, but it can be a way for us to try and guess and give estimates. So this is the same thing, 100 patients, you line them, and based on the time it took for the lymphoma to start getting worse, you get to the middle patient, that's the median time to progression, which sometimes the doctor might say, on average, the treatment works for 5 years. It's not really average. I don't want to get technical of average and median and maths and statistics, but that's what we really mean. It's really the median. It's not the average. We don't usually report averages for clinical trials. And then there's a fancier way to look at this, something called the Kaplan-Meier curves or the KM curves. So we start at time 0. This is when we start treatment for all of these patients. At that point, everyone is at 100% because we just started. And then we follow these patients over time. Each time a patient or more have disease progression, the curve will take a step down, and then we follow them over time. And then we look at the 50% landmark, and we look at the number. So for example, in the second curve, at 50% was around 15 months. So that's the median time to progression. This is from a clinical trial in Waldenstrom. There was a group of patients who received ibrutinib with rituximab. That's the green curve. Another group who just received rituximab with placebo. And you can see that the ibrutinib group was higher. That's better because there were fewer steps down. That means fewer patients progressed or had the lymphoma worsen. So sometimes doctors can show these curves when they give talks. So you, in case that's helpful. Okay, let's talk about treatments. So there's something called plasmapheresis or apheresis. This is just really a way to filter out the IgM. So again, the IgM is a very big molecule. If there's a lot of it, it can cause symptoms and complications. If I give a treatment that works right away and it kills all the B cells, it's still going to take actually a few weeks for the IgM to disappear from the blood, even if I turn off all the B cells right away. So if the patient is having serious symptoms from the IgM, we can't wait for weeks and sometimes. We have to take it out. And that's what the plasmapheresis is. It's basically we place a line in the patient's arm or neck. We take this blood, it goes through a machine, and this machine just filters out the IgM and give the patients the rest of the blood back. So we get rid of the IgM. Now, if we don't give a treatment that will kill the lymphoma cells or slow them down, the IgM is going to bounce back up. So we have to do both in conjunction or in combination. We have to give a treatment that will kill the lymphoma cells or slow them down. And if indicated, we need to get the IgM out of their body. So we use it when patients have hyperviscosity, we do that. Or if they have complications directly related to the IgM and they're serious complications, then we have to get rid of the IgM quickly. The second treatment is rituximab. That's a type of immunotherapy that's been approved in lymphoma for more than 25 years. It's actually an antibody too. It's this Y-shaped protein. It's designed in a way that it can bind to CD20. CD20 is a protein on the surface of B cells, including lymphoma B cells. When the rituximab binds to these cells that have CD20, it will kill them. It first will flag these cells so that the immune system can actually go and attack and kill the lymphoma cells. It can also induce pores or holes in the surface of the B cell, so the cell will rupture and die. Also, if the cells are coated with this rituximab, sometimes they'll just commit suicide and kill themselves. So it works in kind of different ways based on the immune system. It's typically given intravenously every week for 4 weeks. It can sometimes be given under the skin as an injection. Sometimes there could be different treatment schedules, so not just necessarily weekly weekly for 4 weeks. Sometimes there could be more frequent dosing. It works in around 25 to 50%, so not great. And it works for the median of a year to 2, so also not great. So if I give Rituxan to a patient, I'm not expecting it to work for 5 or 10 years. Sometimes we get pleasantly surprised, and it does work for 5 or 10 years, but that's not the expectation. So we rarely use it if someone has major symptoms, if they have a lot of disease, because the expectations are low. We use it with other things, but we don't use it alone. It can be beneficial if the patient doesn't have a lot of disease. So if a patient has fatigue, the lymph nodes are not very large, the IgM is not very high, the blood counts are okay, I don't want to really give them chemotherapy because I think it might be too much. I don't want to commit them to a pill for many years. I might say, let's try rituximab, but there's at least 50% chance it's not going to work. And even if it works, I'm not expecting it to work for 5 or 10 years. But for some patients, it's reasonable to try. It tends to be a good option for some of the complications that are from the IgM. For example, if a patient has this hemolytic anemia where the immune system is attacking the red blood cells, rituximab can be a great option. Or if maybe they have peripheral neuropathy, it might be a good option to start with. It's slow to work. It takes weeks to months. If a patient has serious symptoms or urgent symptoms, we can't just give Rituxan alone. We have to do something else. It can cause something called the IgM flare. So for some reason, when we give the Rituxan, the IgM levels sometimes will go up before they go down. So if we start and the IgM levels are very high, when I give Rituxan, I can actually sometimes create new problems for the patients. Because if the IgM is very high and I'm going to make it higher with my treatment, that can trigger hyperviscosity. So if the IgM level is more than 4,000, we're very cautious. We typically don't give Rituxan. We either do the plasmapheresis to bring the IgM down and then give Rituxan, or we start with other treatment and then add Rituxan later when the IgM is under better control. There's something called infusion reactions. These are very common when we give Rituxan. So people can have fevers, chills, rashes, shortness of breath while Rituxan is running. They're relatively common during the first time, but they're much less common with subsequent infusion. And then even though it's called immunotherapy, it can actually weaken the immune system and increase the risk of infection. So that's very important. But overall, it's one of the milder forms of treatment. We don't expect significant fatigue. It's not going to lower your blood counts for the most part. You're not going to lose your hair from it. It's a milder form of treatment. The second option is we combine rituximab with a chemotherapy called bendamustine, and we call this combination BR. So bendamustine is chemotherapy that's given through the IV, is given 2 days back to back every 4 weeks for up to 6 cycles or 6 rounds. So that's around 6 months of treatment. Sometimes we might just stop at 4 cycles if the patient's having a lot of side effects or we're worried about them. So at least 4 months of treatment for most patients. It's very effective. It does work for more than 90% of the patients, and it works for a median of 5 years. So the example I gave before, that could be a great demonstration of what would happen if I gave bendamustine and Rituxan for 11 patients. And after 15 years, I line them up. The 6th patient is probably going to be at the 5-year mark. That's what we would expect with bendamustine. The side effects are what you expect with chemotherapy, but it does not cause hair loss, which is great. Fatigue is very common. Most patients will come in and say they have fatigue. It's not usually severe or debilitating for most patients, although this can vary. It kind of depends on the patient's age, how strong or weak they were before we started. It tends to get worse as we give more bendamustine. But almost all patients will have some degree of fatigue. Most of the time, not to the point where you can't do most of the things you want to do. It's not that severe for most patients. If the patient is in good shape before we start treatment. Nausea is common, but most people don't vomit. We have very good nausea medications. Low blood counts is a very common problem with bendamustine. It can take weeks, sometimes even months for the blood counts to recover. Sometimes they don't even recover fully. Rash and itching can happen. Risk of infections is probably the most important one. This one will really weaken your immune system. You have to be very careful. And it can take the immune system months or even years to recover. So it could be infection just like COVID or the flu or the common cold, or even bacterial infections like UTIs or other types of pneumonias. And so that's a big deal. The patient has to be cautious. That doesn't mean you have to quarantine for years. No, but you just kind of have to be mindful about the fact that you're immunocompromised. And then all types of chemotherapy, but including particularly bendamustine, has a very low risk of causing blood cancers, not lymphoma, other types of blood cancer, something called myelodysplastic syndrome or MDS, or acute leukemias. The risk, fortunately, is very, very low, less than 5%, probably even close to 2 or 3%. But if these happen, they can be serious and life-threatening. So it's something we always have in our mind, we monitor for. Fortunately, the risk is low, but it can happen. Okay, the third option is also chemotherapy. It's this DRC regimen. D stands for dexamethasone, that's steroid pills. R is Rituxan again, and C is cyclophosphamide. These are chemotherapy pills. This is given every 3 to 4 weeks. It's not as good as the BR, it's not as effective. The chances of it working are lower. It doesn't usually work for long, but it's usually or typically milder or easier than the BR. So if I have an older patient where I'm just worried that they're not going to do well with BR, and for some reason I don't want to give them the other treatment options that I'm going to mention, this could be a good option. It's more popular in Europe, but it's used in the US. I've used it before for some patients, and it can be a good option for the right patient. Another treatment option is something called the BTK inhibitors. So BTK stands for Bruton tyrosine kinase. So the BTK is a protein inside the cell. So let's start here. So that this is a normal, happy-looking B cell, immune cell. It's not cancerous, it's normal. And there's a virus in the body. This B cell will get a signal that there's something wrong, there's an infection. So now it has to grow, it has to proliferate, it has to make copies or copies of itself, and it has to make more of these antibodies to fight the infections. And to do all of that, this BTK protein inside the cell has to get turned on. It's like a signal inside the cell that, the B cell, do your job, make these antibodies because there's an infection. So this is just normal now. Now, sometimes in cancer and lymphoma, there could be mutations in this BTK protein or the DNA that makes this BTK protein, or some other mutations that somehow will get this signal jammed or stuck on. And so the cell will continue to grow, proliferate, make more clones of itself, continue to make excessive amount of abnormal proteins. And that's obviously a problem because that's what can lead to lymphoma or cancer in general. So these inhibitors basically are a way to lock or block this BTK. It's the BTK inhibitor, the pill, is just a protein that will kind of latch to the BTK inside the cell and stop it from working, will turn off the signal. And that eventually will kill the lymphoma cells or slow it down and make it produce less of the abnormal antibody. So the BTK inhibitors are, two of them are approved in Waldenstrom. The first one is called ibrutinib, and the second one is called zanubrutinib. Acalabrutinib is approved in other types of lymphomas. We don't commonly use it in Waldenstrom, although sometimes I see physicians kind of sometimes use it, which is fine. But the preference in general is for zanubrutinib because it's FDA approved and it's safer than ibrutinib. So it's safer than ibrutinib and at least as good. If you're already on ibrutinib and you're doing well, you don't have to switch. But it's very uncommon for us now to start a new patient on ibrutinib because, again, Zanu is safer and at least as good. It might actually be a little bit better. These are pills you take once or twice a day, and you stay on them for as long as they're working. And that could potentially be years because they do work in most patients and they tend to work for years. The median time to progression is also 5 to 6 years. So just similar to the BR, just similar to the example I gave you earlier, the same group could have been all given zanubrutinib, and the sixth person, the middle person, if I ask them, they're likely going to tell me it was 5 years. The side effects are a little bit different. The zanubrutinib can inhibit the platelet function, so it can increase the risk of bleeding and bruising. Bruising is very common. Most of the time, there's just small bruises, but sometimes they're a little bit bigger, they can be annoying. Fortunately, the risk of bleeding, serious bleeding, is low, but you have something to monitor, so it could increase the risk of vomiting blood or coughing up blood or having blood in urine, for example. Diarrhea, headaches, and muscle aches are very uncommon with zanubrutinib. If they happen, they tend to be mild. They tend to go away in a matter of days or maybe a couple of weeks. All of these drugs can cause something called AFib or atrial fibrillation. That's an irregular heart rhythm. It happens in maybe 5 to 10% of patients. It's more common in older patients. It's more common if the patient has some other heart or cardiac issues. It can raise the blood pressure. So if you already have hypertension or high blood pressure, it could get worse. It can lower the blood counts, not as much as chemotherapy, but we could still see low blood counts from it. It can cause infections too, so it does weaken the immune system, not as much as chemo, but remember you're staying on it for a longer period of time, so that's still very important. And then there's something that can also sometimes cause this IgM flare, where the IgM will just go up if you stop it abruptly. And so if you have to stop it for some reason, just talk to your lymphoma doctor, because it's kind of important to know that your lymphoma is under control before you have to stop it. Otherwise, it could get kind of flared or triggered if you have to stop it for some reason. Pirtobrutinib is another type of BTK inhibitors. It's not actually approved in Waldenstrom. We can use it sometimes off-label in patients who receive a BTK inhibitor or chemo and then the lymphoma comes back again. There are studies using pirtobrutinib as a first-line option, so that's why I included it, but it's not something we can give to patients right now. The other class of drugs is called the proteasome inhibitors. So these proteasomes are just like garbage disposals. So if you imagine these B cells making a lot of these proteins and antibodies, just like a factory, you can imagine there's going to be just a lot of waste. And these proteasomes are supposed to recycle this waste and get rid of it. If we give a drug that inhibits these garbage disposals, the waste is just going to accumulate inside the cell, and the cell eventually is going to burst and die. And that's how they work. There are three drugs in this class, at least three drugs in this class. Bortezomib or Velcade is probably the most popular one. It's given as an injection under the skin. There's carfilzomib, which is an intravenous injection, and ixazomib is an oral drug. They're usually given in combination with other drugs. It's not common for us to just give them or use them alone. They tend to work very quickly, and that's really probably the biggest advantage of them. So if I have a patient with hyperviscosity, I'm doing this plasmapheresis, and I need to stop the cells from making new antibodies, the Velcade or the bortezomib might be a really good option to do that. The main problem is that numbness and tingling or neuropathy is a very common side effect of them. They're also a common symptom in patients with Waldenstrom. So most of the time we can't use them for long. They're also not as good as the other options like the BTK inhibitors and the BR. So those other options are more popular, but sometimes we use them. Okay, so I mentioned, maybe I've given the impression already that zanubrutinib and BR are kind of the favorite treatment options, and they are. I made this table to try and compare and contrast between them, because for a lot of patients, I go in and say, not for all patients, but for a lot of them, we have this great option with zanubrutinib, we have this great option with BR. Let's go over both options and decide what's best for you. The BR is chemotherapy is given through the IV, again, 2 days back to back, every 4 weeks for 4 to 6 months. The zanubrutinib is a pill you take once or twice daily, you stay on it potentially for years. The BR can work faster. So if it's really important to get the IgM low quickly, or if the patient has severe symptoms where delaying response for a week or 2 or 3 might be a problem, we might favor the BR. This is not very common, but it can happen sometimes. This is not saying that Zanu doesn't work quickly. It does actually for most patients. When I give Zanu and see patients in clinic a month later, most of the time I see improvement in their labs and how they're feeling. But sometimes in emergencies, a difference of a week or 2 can be important. They're both highly effective. In fact, as far as we know, they're probably both equally effective. So that's not typically a major decision, the major factor to decide on one or the other. Low blood counts is way more common and tend to more likely to be severe with BR than with Zanu. Zanu can still lower the blood counts, but not as commonly and not as severely as with BR. The infection risk with BR is higher than Zanu, although infections are still very important even with zanubrutinib. BR doesn't typically affect the heart in a negative way. I mentioned this risk of atrial fibrillation, high blood pressure, and other abnormal heart rhythms with Zanu, even though the risk is very low. But it's not something we see with BR. The risk of bleeding is higher with Zanu. Now, BR can lower the platelet count, which could increase the risk of bleeding, but Zanu by itself will inhibit the platelets and how they work, and that can increase the risk of infection. I mentioned that there's a small but significant risk of having other blood cancers from the BR itself. That's not the case with Zanu as far as we know. And then with BR, the cost is just treatment for 6 months, and it's infusion, so most of the time it goes with a deductible, and it's not a problem for most patients. Zanu as a pill cost sometimes can be prohibitive for some patients because you're gonna might have a high copayment and you're likely gonna stay on it for many years. So that sometimes is a problem for some patients. There are some programs and grants to try and help with the cost, but sometimes it is still a problem for some patients. So in my mind, BR might be a better option or favored for some patients if they really just want a time-limited treatment. They want to get treated for 6 months and they want to forget about the Waldenstrom, hopefully for years. And if they're fit for chemo. So if they're very weak to start with, I'm going to be worried about them. I might favor the Xanu because it's relatively easier. It's favored if we really need to see a good response early on, as soon as possible. And it's favored for this condition, the amyloidosis, because Xanu and ibrutinib don't work great for this. Xanu might be preferred if patients want pills rather than infusions and coming to clinic twice a month. It may be in older or frail patients where I'm really worried about the fatigue, the weight loss, the risk of infections, or if the patient just wants to avoid chemotherapy. And then for this syndrome, the Bing-Neal syndrome, that's when the lymphoma is involving the central nervous system. Xanu tends to work. We believe that Xanu is the best option for that syndrome. It might be better than chemo. Okay, so this is kind of my treatment approach, or a common treatment approach. This is not saying this is the only right treatment approach. There's a lot of generalization here, but just kind of to give you an idea of what we recommend for most patients. The first question is treatment indicated, yes or no? If no, then we just watch and observe. We don't do treatment. If treatment is indicated, we really should think about clinical trials. I encourage you to ask about clinical trials. Just ask your doctor. Hopefully they bring it up, but if they don't, ask about it. That doesn't mean that clinical trial is always the best option, but it could be. This is how we come up with new treatment options, more effective and hopefully safer. And for most patients, it's a selection between zanubrutinib or BR for most patients. And then if we start with one and the lymphoma doesn't respond or comes back, start growing again, we typically go to the other one as long as the patient is able to receive the other one. After that, these are probably the most common used drugs other than BR and Xanu. So venetoclax, which I didn't mention because that's not a treatment for newly diagnosed patients, and then pirtobrutinib, the other BTK inhibitor, and then the proteasome inhibitors. Okay. Thankfully, we have very good treatment options, but we know there's still room for improvement and need for improvement. There are a lot of clinical trials testing new drugs and combinations of drugs that will hopefully improve outcomes for all patients, including those with newly diagnosed Waldenstrom. We hope one day we're going to be able to say, yes, we can cure Waldenstrom, where a patient takes treatment for 6 months or a year maybe, and hopefully it's not chemotherapy, just pills that they tolerate well, and hopefully not needing treatment for many, many years, and hopefully the lymphoma won't even come at some point. We're not there yet, but I believe we're heading there because of all the exciting new treatments and combinations in Waldenstrom. And with that, any questions? Yes, go ahead, please.
Two-part question. Do you routinely look for the presence of the XBR4 mutation in the patient? And does the presence of that mutation influence treatment?
Yeah, so that's a very good question. So the question is, do we routinely look for the CXCR4 mutation? And if it's present, does that change my treatment? Yeah, at OSU, we do. We have a panel that would check for the NYD88, the CXCR4, the TP53, and a bunch of other mutations. So for us, it's routine. I would say that's not done everywhere, especially in the community. So if the patient had the bone marrow biopsy in the community first, it might not be done. We typically request the slides and most of the time are able to test it later, but not always. It seems like the CXCR4 makes both BR and Xanu less effective as treatment options. So that doesn't necessarily changes my approach. Some physicians might say the evidence that they might favor the BTK inhibitors sometimes, because if the biggest advantage of BR is to say, I'm going to give you 6 months of treatment and then hopefully not worry about the lymphoma for long. But if the lymphoma is going to start growing relatively soon after chemo, some physicians might think that the BR is not advantageous anymore because you're not expecting 5 or 10 years, for example. Even though I'm going to say again, even though we say patients with the mutation, the lymphoma is generally more resistant, that doesn't mean the treatment can't work for 5 or 10 years, but the chances are lower than in patients without the mutation. I hope that makes sense. Okay. Thanks. Yeah, go ahead, please.
When you were talking about the determining the progression, the risk of progression, you said, I think, that the IgM would have to go up 25% or more in 2 consecutive
Correct.
visits. What's the time frame for the visit?
There's no specific time frame. It kind of depends on the patient. So I typically see patients every 3 months at least. If I'm concerned the patient has new symptoms, if the blood counts are getting worse, am I more worried I might repeat it in a month? If the patient is really doing fine and the blood counts are fine, I might just repeat it in 3 months. The thing that I didn't talk about is even if the lymphoma is actually progressing, that doesn't necessarily mean you have to start a new treatment right away. So just like we can observe patients with newly diagnosed Waldenstrom, we can also observe patients or much just monitor them even after the lymphoma start getting worse after the treatment. So if I give a patient BR and then 5 years later the IgM is starting to go up, but the level is not very high, they're feeling fine, I might say, yes, the lymphoma is progressing, but let's just keep an eye on things. So just to kind of give you an idea, there's no always kind of urgent need to check it like within a week or two, for example. Most of the time, that's actually not the case. Unless the IgM level is very high, then I might kind of favor close monitoring. But if the level is not very high, if the patient is feeling well, probably a month to 3, depending on the scenario for most patients. Go ahead.
No treatment is included yet during the observation phase. You said the IgM can wax and wane.
Yes.
So do you have any idea what makes it wax and wane? And for anything,
Yeah. We don't know. I can tell you if you're in the hospital and we check your IgM every day, we're not going to get the same reading every day. It's going to be a different reading every day. So some of it's just the error in measurement. It also varies from a lab to another. So sometimes I'll see a patient, they had the IgM checked at the other hospital a week before I see them. I check it again in the clinic. I get a significantly different number. It's unlikely that the lymphoma gets so much worse in a week. It's likely just the different labs. In terms of what you can do, I know there are other sessions about diet and exercise and meditation. We don't have very strong evidence that kind of link these things to how the lymphoma is going to act or going to behave. I do think just having good overall health is definitely in your favor in so many ways, because the healthier you are before you need treatment, then the healthier you are when you need treatment, and then you're more likely to tolerate treatment and do well with it and stay longer on it. So I think things like eating healthy, exercising, taking care of yourself, mentally, all of these things will definitely help you in a way or another. I don't know if they're necessarily going to make your IgM level go down. I sometimes also don't want to feel like the burden is on the patient, where if they don't exercise and eat healthy, their IgM is going to go up. And if you eat ice cream tomorrow, your IgM is going to go up. It doesn't work that way. Don't eat ice cream twice a day, every day. That's not good for your health for so many reasons. And diet can definitely impact our health in so many ways. I'm sure there's a connection to lymphoma, but I can't link it directly. And I sometimes kind of hate to make it seem like if the IgM goes up, that means that the patient did something wrong. No. In fact, we don't have any proof. We don't really know why these lymphomas happen, but we can't pinpoint anything that patients do that will make them get this lymphoma. So it's no one's fault that they get Waldenstrom. It's something that happened. Take care of yourself, eat healthy, exercise, but I don't want to burden you with the thought that if you don't do that, the IgM is going to go up. Go ahead, please.
I have several patients in my support group that have started with the bruising or later on started. And then they have some side effects. One in particular has lower back pain and they're debating about switching to Xanafrutinib. So the question relates to, is it possible or likely to maybe have some problems with the Brutinib and then switch to Xanafrutinib, particularly with this lower back pain?
I don't know about lower back pain. Muscle spasms are relatively common with ibrutinib. I don't know if that's what's happening with this particular patient, but there are data that there are some side effects that happen with ibrutinib that just don't happen with Xanu. And there are patients who can't tolerate ibrutinib but will tolerate zanubrutinib. So I would say if there's suspicion, I think it's reasonable to switch them to Xanu and see if that helps or not. You're not losing anything in efficacy, but it could potentially help with the side effects. Go ahead.
Is it possible to give chemotherapy to someone who's already on chemotherapy?
Yeah, we get really nervous about doing that, and with BR we typically don't do that because that's a common side effect of all types of chemotherapy is low blood counts, and that's a major side effect of bendamustine. So we typically don't do that. And so if a patient is on another treatment for another cancer and they really need treatment for Waldenstrom, we probably won't give them the bendamustine. And bendamustine doesn't typically work for other types of cancer, like prostate cancer, lung cancer. It doesn't work. It's mostly for lymphomas. So in these cases, if we really have to treat, it probably would be the other options, either Rituxan alone or the zanubrutinib or maybe the proteasome inhibitors, but probably not the bendamustine. Yeah, go ahead.
Initial bone marrow biopsy and that confirmed Waldenstrom. Is there any time that it's advisable to repeat a bone marrow biopsy?
If we give a treatment and it doesn't seem like the patient is responding, especially in the low blood counts, so if I give BR, for example, to Waldenstrom, and then a year later the blood counts are still low, the IgM improved, so that's a good sign, but that doesn't necessarily mean that the lymphoma has cleared enough from the bone marrow. I also mentioned the risk of having other blood cancers from the treatment itself. So I might do a bone marrow biopsy to see actually if there's still lymphoma in the bone marrow or not, or how much. Is it enough to explain the low blood counts, and just to make sure that the treatment itself didn't cause another type of blood cancer. If you're on zanubrutinib, for example, we only would do it if the patient is having symptoms or low blood counts, and we're not sure if it's the lymphoma getting worse or a side effect of Xanu, or maybe it's something else. So we don't routinely do them unless there's an indication, and most of the time it's low blood counts, which we're not sure if it's from the lymphoma or side effect treatment or something else. But it's not something we routinely do. If you're in a clinical trial, you probably will get them done routinely. It could be every 6 months or a year, depending on the clinical trial. In clinical trial, there are stricter kind of, response criteria. We have to know if the patient is in CR or not. They want to get research samples to study how the treatment is working and why it stops working. So they might require bone marrow biopsies more often than we typically do in routine care. Go ahead.
If you have one of those people that has had a community bone marrow test, it doesn't have the mutations, and they come to you and they're looking like they need treatment, do you rerun it to find out if you have the mutations or just do treatment?
Most of the time, I want to see the MYD88 at least, and then the CXCR4. So a lot of times we're just able to do these tests on the samples that we commonly request to be sent to us. If for some reason the samples can't be found, then it depends on kind of my suspicion. Am I confident that I'm dealing with Waldenstrom, or maybe it's another type of lymphoma? Most of the time I do want to know, because that might change how I approach it. And then even though, bone marrow biopsies can be bothersome for patients. I know it's not a fun procedure to have it done. I've done it before. I've never had it done on myself, but I've done them to patients before. I know it's not a fun procedure, but it's relatively safe. And if we have concerns that we're not really, dealing with Waldenstrom, we might just say, let's just do it here at the place where I'm treating the patient, and then get the sample, the mutations done. The CXCR4 is good to just kind of counsel patients about the risks and what to expect from treatment. But right now, it doesn't change treatment most of the times. So that's not necessarily a reason to repeat a bone marrow biopsy. And the MYD8, a lot of times it's done even in the community. And then the TP53 is very, very uncommon to see when patients first come in. It's more common as patients go through different treatments. Did I answer your question? So it kind of depends on the case if I would repeat a biopsy or not. If I'm concerned about the diagnosis, if it's not confirmed, I might just want to see the MYD8 because I want to make sure it's not a different type of lymphoma. And so if that's not the case, then maybe I won't have to repeat the bone marrow biopsy. But at the same time, because it's a safe procedure, if I have doubts, I'm just gonna try and get either the sample from outside or just have the bone marrow biopsy done at the institution. Go ahead.
At some point now, considering clinical trials, my layperson's understanding is that would be done after preliminary treatments and proven unsuccessful. Is that right? Do you think so?
So there could be different clinical trial options. Sometimes it kind of depends on the time and the institution. These trials kind of come and go. There are clinical trial options for patients with Waldenstrom who've never had any treatment before. They're not as common as patients who've been through multiple treatments. So it kind of depends on the scenario. But no, you can go on a trial for patients who've never been treated for Waldenstrom before. So this is how, for example, zanubrutinib eventually got approved, and even ibrutinib. There were clinical trials in patients who've never had treatment before, and then we gave them ibrutinib and zanu, and they did so well that they were approved. Go ahead.
If you have low platelets and you're going to start a treatment, and zanubrutinib causes platelets to increase further, is it still recommended?
So zanu can lower the platelet count, but that's not very common actually. Even if it doesn't lower the platelet count, the platelets that are already in the body can be affected by zanu, where they just don't function as normally. Most of the time, yes, we're able to give zanu if the platelet count is more than 30 to 50,000. If the platelet count is less than 30,000, we get nervous about using it, but we might still use it if we believe that this is just from the lymphoma, and we think the lymphoma is going to respond to zanu quickly, and then the platelet count will eventually improve. We might sometimes give transfusions for patients. So if we think the low platelet count is from lymphoma, we're going to give zanu. We'll start zanu, kind of keep a close eye on the patient. If the platelet count recovers, great. If we need to give them some transfusion to support them during the first few weeks while zanu is working, we can do that too. It's very uncommon where we see a patient where we just say, no, we can't give you zanu because your platelet count is very low if it's from the lymphoma. If it's from something else, then sometimes that can be a problem. If they received chemotherapy before and their platelet count is very low for years, well, then it's not going to get better, from zanu, and that might make it in kind of harder situation. If a patient has active bleeding, then also it becomes more challenging. So if they're bleeding, they have an ulcer in their stomach and they're bleeding, that makes giving zanubrutinib sometimes very challenging, and that might favor using other treatment options. Go ahead.
We're thinking many of the people who come to you are also dealing with multiple other issues. So for those folks, let's say you have coronary heart disease already on aspirin, can you use these medicines with aspirin since they both inhibit platelets?
Yeah, so the risk of bleeding with zanubrutinib is not that high, where we can't combine it with other blood thinners. So aspirin, Plavix, Eliquis, Xarelto, all of these types of blood thinners are okay to use. The risk of bleeding does become higher, so you have to be careful. And there's an active bleeding that will make us nervous, and maybe wouldn't even use zanu. I would say the main blood thinner that we get really, really nervous about giving, I typically don't give zanu with, is Coumadin or warfarin, because the risk of bleeding with that one is just much, much higher. And there's a significant risk of having serious and potentially life-threatening bleeding, including bleeding in the brain, that we typically don't give zanu in general. We don't give it with Coumadin or warfarin. But the other blood thinners, as long as there's no active bleeding, it's okay to give zanu.
My oncologist mentioned that there are some new trials that are approved by the NCI, and it's comparing zanubrutinib to venetoclax and rituximab in combination. Do you have any information about?
I don't have information about the specific trial. I would say that sounds like a good clinical trial to consider. Venetoclax, we know, is active in Waldenstrom. It's not approved in Waldenstrom, but it's used in patients who've been through other types of treatment like zanubrutinib or BR or the proteasome inhibitors. It can work in a significant percentage of patients. A potential advantage of venetoclax is that maybe it can be given for just a limited time, so maybe 2 years or 3 years rather than indefinitely. So that can be an attractive option for some patients. Which one is better? We don't know. That's why we need these clinical trials. And there are a lot of trials combining venetoclax and a drug called sonrotoclax, which works similar to venetoclax, with zanubrutinib and other BTK inhibitors, because these classes of drugs tend to complement each other. So that's an area of active investigation, trying to use venetoclax or this class of drugs alone or in combination with other drugs like the BTK inhibitors. But that could be a very good trial. I would consider it.
It felt like there were hundreds of, like it's something new, and it's for untreated.
Yeah. I honestly, I don't, I mean, it sounds like a good idea, and I'm sure, yeah, it's so venetoclax is approved in other types of lymphomas. It's used a lot. We know for sure it works in Waldenstrom. Is it as good as Xanu? Is it better than Xanu? We don't know. So that trial could answer that question. I think if you go on a trial and get venetoclax, that's a great thing, because if it works for you, that's great. If it doesn't, then you can just go on Xanu without the trial. So it gives you an extra option. Go ahead.
Exactly. So, family cluster. They're like, oh, I'll have it. What are the chances of like?
Yeah. Very low. Slightly increased compared to the general population, but still slightly low. Like we wouldn't recommend screening to your family members if they don't have any symptoms, for example. This is not a hereditary type of cancer. So breast cancer, colon cancer, like sometimes if you have enough family members affected, your risk could be 25 or 50%, for example. This is not the case with Waldenstrom. I don't know the exact numbers, but it's a very low percentage, higher than the general population, but still very, very low, and odds that they won't have it. Obviously, if they have symptoms, they should be seen, but we wouldn't recommend routine screening for like check the IgM or blood counts, etc. Go ahead.
What is the mechanism for like the BTK inhibitors to stop working? What's occurring?
Yeah, that's a good question. So the cancer cells sometimes can be smart. So if this BTK inhibitor is binding to the BTK to stop it, well, the cell sometimes can change how the BTK protein looks like. And so if it changes, the BTK inhibitor can't bind to it anymore, and so it doesn't work. Or the cells could activate other proteins that would bypass the BTK, and so the BTK inhibitor doesn't do anything anymore. Okay, sorry. Okay. I'm going to be around if anyone has any other questions. Thank you.